So let me just get through those. As hopefully I'm Jen Kovich-Bordnick, still CEO of eHealth Initiative and Foundation here in Washington, D.C., and welcome today. A couple of housekeeping items. As usual, I think everybody's getting real used to Zoom, so we don't need to do the major review here of Zoom, but we are using the Q&A box today. So if you have a question, please put it in that Q&A box there in the bottom and not the chat box. It'll be easier for us to track and make sure we get to your question. Next slide. Okay, so as I mentioned, we're going to be talking about behavioral health. The landscape, we'll be talking about telemental health today. We've got some really interesting digital mental health tools to talk about as well. And we're going to be talking about the workflow for virtual therapy sessions, which is a little bit different. So an interesting group of topics here today. And then we will get to the audience questions at the end. So please start putting your questions in now. If you have one or you had one you registered with that you really want answered, you're welcome to stick it in there. We also welcome your comments. So if you have comments as we're going along, the speakers love to get those as well. If you've seen something in your organization or you agree, let us know and give us that feedback. Next slide. Three really stellar folks with us here today. Ken Cahill, who's the CEO of Silver Cloud Health, is going to be sharing with us a really interesting tool. And can't wait to hear from him. We also have Dr. Lindsay Henderson, who is a director of psychological services at Amwell. Actually out there in the field delivering therapy virtually online, is going to give us a really unique and interesting perspective. The challenges with that. And then we've got Yana Capaccio, who's the director of clinical initiative implementation at Horizon Health Services. It's great to have a provider perspective, and we're glad that she's here with us today. And she's going to talk a little bit just about how it is to implement this stuff out in the field as well. So a really great group to address you today, and we're going to try to keep it as interesting and as engaging as possible. Next slide. For those of you who aren't familiar with EHI, eHealth Initiative, we are a catalyst for healthcare transformation. We convene executives from across the industry, and our goal is really to figure out how do you use innovation to transform care. So hopefully you have joined us for our education sessions, our thought leadership groups, or you're on the Hill with us with our advocacy efforts, but we are interested in getting as many folks involved as possible. Next slide. This is just a sampling of some of the executives that we work with on our programs. If you don't see the name of your company or your logo up there, we really want to get engaged with you. So please send me a note through the chat box so we can reach out to you and get in touch. We have so many really exciting programs going on right now, and we would love to get you engaged if you are not already. Next slide. We are focused on 4 key areas this year: SDOH, social determinants of health, consumer privacy of health data, another really important topic all over the news, and virtual care, as we will also be talking about today. And then finally, as everybody has been focused on really over the last, gosh, I think it's 18 months now, COVID-19. And this topic certainly overlaps with that as it became much more used during the pandemic. So we'll touch on that today as well. Next slide. A slew of resources available for you online at www.ehidc.org. We are a very small nonprofit, so all of our products, our research, our advocacy, everything's available to you free of charge online, and we encourage you to go and download those. A lot of great reports on social determinants of health, different communities, health equity that are struggling with this right now. So please go and download those reports, share them. Next slide. And finally, we want you to join the conversation. We've got a really engaging group online on LinkedIn, so please join our SDOH and Health Equity Warriors. Nice fun group there on LinkedIn, and we are having some really interesting discussions and just sharing information online, so we'd love to have you join us there. If you haven't already, go ahead and register. We've got a 2-day virtual summit, November 3rd and 4th, on digital health equity. All kinds of speakers lined up from across the spectrum of healthcare. Again, free of charge. Please join us. Great topics, and we're interested in you attending. Go ahead. And last but not least, as I mentioned, we are a very small nonprofit, and we wouldn't be able to have really meaningful programs like this without the generous support of organizations like Amwell. And we're fortunate that Amwell is helping to support this educational effort. So we really appreciate that. All right, let's take this down and go ahead and get started. And what I'd like to do first is actually just start off with Lindsay, if it's okay if I call you that. Sure. Okay. And so Lindsay is actually out there in the field doing therapy. And what we wanted her to do was, first of all, kind of give her, what's your perspective in terms of what this looks like from the provider's point of view, virtual care, how's it different? And then also just, because of Amwell, we know you've got some great information about how often this is being used, et cetera.
Sure. So thank you very much, Jen. This is such a huge topic, behavioral health care and telehealth in the last, 18 months in particular, and one that I've spent a lot of time kind of really tracking and presenting and speaking on. The high level is that telehealth has been an important, and in our opinion at Amwell, of course, a growingly important tool for healthcare and to manage, to better streamline and more effectively deliver care. And there's nowhere, I think, a better example than in mental health, where we can really expand access to care and protect our providers, and their stress and workload and burnout and whatnot, by using technology. So, I feel really lucky that I was already doing this work prior to the pandemic, because I wasn't one of the folks that had to be scrambling in March of 2020 to really figure out how do we do this properly. So I think that that's one thing that we've seen over the last year and a half, is that there are folks, and I know Yana, you'll speak about this a bit more, who have had to figure it out on the fly. And it's amazing how well folks have done. And also this is giving us an opportunity to lead with standards and best practices and trainings and, certificate of training programs, to really make sure that we're all up to speed and practicing the nuances of telehealth or behavioral health via telehealth. Essentially, it's a lot of the same care with mental health care. We are my tool is my voice, or my voice is my tool as a psychologist, and so I'm able to interact with you all in a lot of the same ways that I can in a brick and mortar setting. I don't think it's a surprise that the mental health needs have consistently grown and continue to grow of the American population, and probably and globally as well. Unlike some of the medical, urgent care demands within telehealth, where we've seen kind of big spikes and then lows around flu season and COVID outbreaks, et cetera, as far as telehealth visits and demands go. For mental health, it really has continued to tick up as far as people wanting and needing and recognizing that mental health care is out there and available to them. So the need hasn't slowed down, and we're really looking at, with my colleagues on this call, we're looking at how do we use technology creatively to make sure that we are best taking care of the emotional health of Americans. I think that providers get included in that because this is a very stressful time to be working for certain. But one of the processing an event like a global pandemic and going through kind of the adjustments and coping and grieving, one of the things to strive for is to find meaning in these very difficult and painful and disruptive life, stressors. And for me, some of the meaning I found is that the discussion, the topic, the conversation around mental health has been more normalized, and it's been brought into workplaces and schools and popular media in a way that it hasn't been in the past. That stigma and barriers to access have restricted that a bit. So I think that one of the nice things is that we're talking about this more, and people are demanding and accepting and insisting on good mental health care. And so there's an opportunity to really meet those needs and get creative with technology. I think one of the, I'll stop so we have time for lots of good discussion and questions. But one of the take-home messages is that there is too much mental health work to be done by just individual therapists. The workload and the stress on healthcare providers over the last year and a half is, and I'm one of them. I'm experiencing that, that real kind of my internal reserve is being sort of chipped away, all of us, right? But especially as care providers, it's difficult to care for yourself and provide it for others. So the need is great, and right now there are not enough individual therapists to meet it all. And I think that that's where technology can be a very exciting topic to think about, how beyond just individual one-on-one sessions, which I've got lots of very, neat stories about people getting care for the very first time ever, only because of technology. Beyond that, how can we use digital tools and the brains behind all the technology to just make this make it more accessible for all? So I'll take a breath there.
Yeah. No, I think that that's a great point. And certainly, telehealth virtual care has expanded access and made it much more mainstream. I think that's a really great point. And I think your other point, which is really important, is the fact that the number of people requesting mental health services, behavioral health care right now has significantly skyrocketed. And then there is just not enough staff right now to meet that need. But we've got a lot of really interesting digital health tools right now that are coming out for individuals who might not need the virtual therapy. So I want to switch over to Ken now with SilverCloud, who's got something like that, and talk a little bit. First of all, Ken, welcome. And let folks know, if you would, just kind of what SilverCloud is for folks that don't know, so we can so we're all on the same page.
Certainly, happy to. Well, thank you for the opportunity, and good morning, good afternoon to everyone. My name is Ken Cahill. I am the CEO and the co-founder here at SilverCloud Health. SilverCloud Health is a digital mental health platform. And much more than that, we operate as the trusted partner with health systems, health plans, and indeed large corporate organizations to enable them to deliver effective mental health care at scale. Our vision is effective mental health care for all, and our purpose or our mission is to help people improve their mental health through technology. We are a spin out from well over a decade of research, both academic and clinical research, into the area of how do you deliver digital access to mental health care, and looking at kind of the barriers that existed both then and indeed today, which are digital tools and digital delivery has low patient or user engagement, high patient dropout, and limited clinical improvement. So essentially, when they actually get deployed into the real world, they fall flat. They fail to deliver on what they promised to, or what the hope or the hype was. So that's kind of the background. That's what we do. We've developed over 30 programs across the range of mental health spectrum, moving from your kind of worried well, resilience, living in challenging times, a COVID-specific program we developed, resilience, stress, sleep, for example, full interventional suite then around what you would expect, depression, anxiety, comorbid depression and anxiety, through to insomnia, and then into your more chronic area, such as diabetes and mental health, cardiovascular disease and mental health, for example, because there is such a high comorbidity between mental health challenges and what happens with a chronic disease, to the point we all know that we're all reasonably familiar with a stat that's used, which is 1 in 4. So about 1 in 4 of the global population will have a diagnosable mental health disorder in any given year of their lives, and that's according to the CDC. When you then look at the chronic disease side of the world, it's anywhere between 30% and 75%, depending on which chronic disease it is. And even one which is relatively normalized, as I see it, is diabetes. But 45% of folks who have diabetes will have clinical levels of depression, anxiety, or stress.
Wow.
So it's a huge challenge. It's a huge issue. We've seen a tsunami over the last sort of 18, 24 months that's, I suppose, accelerated the conversation. It's sort of helped destigmatize it to some degree, remove some of the taboo. I know certainly, a conversation you would have had with friends over a coffee or similar 10 years ago, they might have admitted somebody there was stressed in work. I think today you could safely say somebody would feel an awful lot more comfortable to say they have anxiety or are anxious, which is one forward step, limited for the cost of what we've gone through. But so that's kind of where we come from. That's what our focus is. We are prodigiously focused on our North Star, which is about outcomes and data science. So what that means is we focus on delivering the outcomes, the results, and it working in the real world. And the great thing about digital delivery is it's infinitely measurable. What I mean by that is when you use the correct tools that are there today, such as PROs, patient-reported outcomes, like a PHQ-9 for depression, which is used all over the world, GAD-7 for anxiety, you're able to measure pre and post. You're also able to measure midpoints as well. So that coupled with digital delivery being able to measure engagement, access time, satisfaction if the organization or vendor is willing to ask that question, you can very quickly digital deliver something at scale, and also then show a very credible story as to the impact of what this is. And that is, for my industry, what gives me the greatest level of excitement. Not pre-reading the conversation later on in today's session, I think my industry has fallen short on in terms of the transparency around that data, the proven effectiveness, if you will, and that proven effectiveness in the real world. And I think that's why we've moved away from saying we're a digital tool, a digital platform, to more we're a partner. So we've deployed across 300 organizations to date, and they include the NHS in the UK, whereby 80% of every NHS mental health service in the United Kingdom uses our platform to deliver care. Wow. Doesn't mean that we are the silver bullet for everything, but it means that we help them stratify and deliver care that is the most appropriate, in the right context, at the right time, and it's easier and earlier to get access to. And 11 years doing it. And hopefully you can still hear the passion in my voice.
So you're definitely not the silver bullet, you're the silver cloud.
Indeed. And often one of the sort of second most common question I get asked, I'm 6'9", so the first question I get asked is, what height are you? And then the second most common question I get asked is, why silver cloud? And the name comes from essentially every cloud is a silver lining. So we're trying to help people in terms of that reframing. And listen, we're not about developing or giving somebody a crutch. We're about giving them the tools and the toolkit to help them think, act, and feel better, that they will then use and redeploy. And we've done multiple randomized control trials to show, yes, the episodic change between a pre and a post, so before Silver Cloud and 10 weeks in or after Silver Cloud, but then also what's the impact 3, 6, 9, and even 12 months afterwards? And we show a consistent, continued improvement, because again, we're giving people the tools that I know when I grew up, I didn't have access to these tools of how to reframe, think, understand what negative thinking styles, catastrophized thinking is. I just didn't have that access. So I'm very proud to be a small part of helping give that access.
It sounds like you said that you measure basically before they use the tool and after. Can you just let folks know what is the tool exactly? Because it's not
certainly. So
person.
So what we're essentially doing is, if you think about it, it's like we use a mix of things: cognitive behavioral therapy, positive psychology, mindfulness, motivational interviewing technique are some of the main modalities that we would use or we would deliver. And they're delivered for a user would typically access our platform over a 6 to 8 to 10 week period of time During that time, they would go through structured content, but done in a very engaging way. And they will have a coach who will be there asynchronously helping to guide them through. Maybe unlocking modules, unlocking content, directing them towards, maybe you've mentioned anger management to me. Essentially trying to build a therapeutic relationship, if you will, with that client on the other side to help them in terms of what's there. And often we will deliver virtually. Most of the time we will fully do that. But we have a lot of organizations here across the US who will use this as part of either reinforcement between face-to-face sessions or indeed as an adjunct to face-to-face. And I think that mentality that we're not a silver bullet is really important to me. So we're still learning, we're still humble, we still have to make them better, make the industry better, and sort of drive it forward to help the end user.
So it sounds like they engage with it, and as they engage more and more, they're giving kind of customized, they're directed or coached to certain content.
Yeah, for someone explained it to me before, it's this kind of learning curve that we all have naturally built into us, which is essentially when you begin something new, the worst thing that can happen is you get overwhelmed. But as you begin something and over a number of weeks, the worst thing that can happen then is you get underwhelmed. So so activation and engagement, as we call it, or A&E, is such a vital part of what we do and what we focus on to make sure you're not getting pinged, you're not getting nudged, you're not getting annoyed, because we've all disabled those on our apps or on our smartwatches if we have them. So we want to tread a very thin line in terms of helping around engagement. And we've delivered the platform now to over 800,000 active users who've actually used and deployed and delivered with SilverCloud. And I think we've 1,700 paper citations. We have over a dozen randomized control trials and trials working across all the different sectors that you think of. And we're really keen and focused on doing more of them, proving how this can deliver across different styles, shapes, sizes, ages, demographics, social, everything in terms of helping people.
Yeah, this is really interesting stuff. So, and I know we've got questions already, but let's jump over to Yana to talk about kind of from the provider's perspective, Yana. So, so you've got a lot of options. So you can direct people to digital tools, you can direct people to go in person, and you can direct people to go virtually or online. So talk a little bit about kind of what it's been like transitioning to that, and what are the differences in terms of the workflow. So if you have, those are 3 different streams that a patient can go into, and what's the workflow need to be kind of for each of those?
Yeah, so I'll just tell you a little bit about who we are to just kind of put it in context. Please. So I'm with Horizon Health Services. We're located in Western New York. We have about 20 outpatient clinics, so we do both substance use and mental health treatment. We also have a residential and a detox program. So we have about 700 employees, and on any given day right now, we have about 200 different providers on the platform providing telehealth. And by providers, I mean practitioners. So we have all of our clinical staff trained on the telehealth platform, and we're averaging about 2,500 visits a week. Yeah. So we went live with telehealth in November of 2019. So we had, designed our workflows, developed our training.
Right before the pandemic. So.
Right before the pandemic, right? So we had chosen a couple of practitioners and sites that we were going to pilot telehealth, right? To just make sure, we have the right training, we have the right materials, we have the right workflows. And then, March happened, and then we just trained everybody on telehealth. So we were really fortunate to have our trainings developed. But I think as we've, sort of gotten over that initial, oh my God, just bring everybody on the platform, train everybody. I think, so I do all the telehealth trainings for all the clinicians that are onboarding, all the providers that are coming on board. I think what's been really different and what some of our trainings have focused on is really preparing the patient for the telehealth visit. So, as both Ken and Lindsay talked about, some of the patients we're seeing now, this might be the first time that they're in therapy, right? So they've never had therapy. So really talking to them about how telehealth is a little bit different, how to prepare them for their sessions, right? So just given a couple of examples, you know, what do we do if a session fails, right? So technology can fail. Having those conversations about the patients previously, or I mean, we do some in-person visits right now too, but previously, right, if we're doing an in-person visit and the power went out, right, we could continue to have our session. So having those conversations, what if the internet goes out, right? How am I going to follow up with you, right? So having those discussions, so we're being proactive about those. What happens if there's an emergency, right? So historically, if somebody was in the office with me and they were suicidal, right, we would just call 911 or crisis services and they would know where we are. Yeah. So again, you know, just in our workflows, identifying those things, you know, asking the patient where they're located at the time of service so we can get help there. And just making that part of, you know, one of the first questions when they're connecting, like, hey, where are you connecting from today? Just so the practitioners have that information in case, you know, there's a crisis and we need to get help to to our patients. I think the other thing, and this is really, we're talking more and more as you know, telehealth is here to stay. And I think one of the things we're really focusing on is not losing the integrity of the session, right? Really getting the most clinically out of the session. So I think a lot of conversations with our staff and patients have really been about, you know, introducing telehealth, what telehealth is about, how we can make the best use of sessions. So whether or not, you know, it's wearing headphones in the sessions, right? So maybe it's people working at home and there's other, you know, other family members in their home, and how do we keep that session private, right? So introducing, you know, maybe headphones. Where are you going to set up the camera? Do we want to set it up so there's a door behind you, right? So when somebody enters, maybe it's, you know, I mean, most children are back in school now, right? But like during the pandemic, you know, we had lots of people at the house, right? So how do we keep the session? So do we face the camera so it faces the door? So when somebody comes in, so kind of talking, you know, privacy, those conversations, right? So those historically, yes, we had some conversations about privacy with our patients, but really in the session, patient would just come in the office, we would close the door and the session would be private, right? Because it was just the two of us in the office. And then I think just the, you know, the expectations of the session, you know, is there something, do we need to prepare for the session? Is there materials I need to get to you? How am I going to get those materials, right? Because just handing like a worksheet or something, right? We can't do that virtually. So, you know, do we use direct messaging over the platform? Do we use email? Do we mail you things? And then just like, those are all the conversations that historically didn't happen as much, right? Because the patients were with us. So I feel like that's been a lot of our conversations and training about just how do we keep the session, you know, therapeutic? How do we try to eliminate as many distractions as we can during the session? And, you know, during the height of the pandemic, when everybody was home, that was tough, right? So sometimes patients were like, I'm just going to go to the car and sit in the driveway, right? Because that was a place that they could find some privacy when there were several people maybe in the home. So I feel like when it comes to workflows, those are really some more of the just clinical conversations we're having with our staff. Yeah. You know, do they need reading glasses, this pen and paper work? I get distracted sometimes on video visits, right? So, and we serve children too. So is it, you know, bringing in some Play-Doh, right? Or just those things, coloring things, just to keep us and keep the patient engaged in sessions. So I think it's just a lot more preparing for the session.
Let me ask
and I think
you,
we did historically in in-person visits.
yeah, so let me ask you, Yana, and I'll ask Lindsay this as well afterward. So now that the pandemic is starting to, I don't want to say it, like you said, kids are going back to work, more people are returning to offices, vaccines are out. Are you seeing, you said you train all of the clinicians. So are they now, anxious to get back to the in-person, or are you seeing folks remaining in these virtual sessions? Is the preference now the virtual?
I think for us, we're right now, we're still doing a majority of our sessions virtually, but patients are feeling more comfortable coming in, doing some in-person visits. I think it's also sometimes clinically appropriate for them to come in to see us. So I think we have, as things are, as our numbers are kind of going down, I think patients do feel comfortable coming in, but there's some that don't. So we just continue to do just virtual care with them.
Yeah. Lindsay, how about at Amwell, and what are you seeing in your own practice?
Sure. No, it's a great question. And, my lens is at Amwell, we are providing end-to-end, complete treatment episodes virtually. So we were not doing in-person care, before. And so it's a little bit different.
Yeah.
But I think that both patients and providers really love the flexibility and privacy and comfort of telehealth, and will not, I don't think we'll ever return to the amount of in-person visits that existed pre-pandemic. I also think it's important to acknowledge that practicing and receiving telehealth in a pandemic is very different than doing so outside of a pandemic or pre-pandemic, because our entire lives are on screen now, and so it's easier to get kind of burnt, sort of fatigued, less social energy and interaction. There's no the rest of your life isn't sort of balancing out that that connection over telehealth for treatment. So it's an interesting, I think it's harder now to practice exclusively telehealth than it would have been, than it is, outside of a pandemic setting. So my personal opinion is I think hybrid is going to be the way forward, that people will want some combination, or they will want to be able to check in, or use the flexibility of technology. And I think that my hope is that clinicians are going to be able to reduce their risk for burnout and have more fulfilling kind of flexible careers for the longevity because of technology and the freedom it gives them, especially in mental health. So, but certainly this is like force people's hands in a way that, folks may have not jumped into telehealth, both providers and patients, and a lot of them like it now that they're here.
Yeah, interesting. I didn't really think about that we're all kind of living online, and the burnout factor a little bit. Why don't we bring everybody back and do a Brady Bunch style here? One thing I'm really interested in hearing about is, certainly we saw virtual care explode during the pandemic, but I'm interested in what were kind of the behavioral health trends that evolved during the pandemic. And are we still seeing, I would assume everybody was more anxious, so maybe there were more anxiety, issues, patients suffering from anxiety. But I'm just curious, Ken, maybe if you want to kick us off there, what kind of behavioral health trends did you see through the pandemic, and are you continuing to see?
Yeah, I think if we look at the sort of, the United Kingdom, because it's just a closed data set, it's very, very clean. And they also publicly publish all healthcare data in terms of outcomes, recovery, pathways, which vendor, all the rest. It's fascinating to dive into the data that they have. And I was looking at one of my colleagues kind of sent me on a report from it. So pre-pandemic, we've been working our way slowly up to around 6% of all mental health deliveries in the UK across every form, type, facet, everything else like that. The first delivery was SilverCloud. During the height of the pandemic, kind of this time, summer last year, about 37, 38, 39% of all mental health delivery in the United Kingdom was via our platform. And post that, it's up around 17, 18% today. So 6, nearly 40, and nearly 20. So when people kind of go, well, it's going to go back to, it hasn't, and it's completely stabilized like that for probably 7 months now. If anything, it's actually slightly coming back up again. But what we've definitely seen is a higher severity than we've had before. And we'd always be used for proper delivery, not just the worried well, but we have seen people coming onto the platform who were more challenged.
Is it primarily anxiety issues? Is it depression? You know, what are some of the conditions primarily that you're treating?
I think it's really hard to boil them all down into one area, because we deliver programs across everything from health anxiety to OCD to phobia to fear, and there's slightly different variants on it. The most common measurement tool that we would, what's interesting actually for people when I explain this to them, in the United Kingdom, they are fanatical about outcomes, access, quality of care, and cost reduction. Fanatical about it. And they measure outcomes very, very strictly. So any vendor, both be you delivering face-to-face care, telephonic, bibliotherapy, group therapy, or digital delivery, you all have to measure the same way, which is, we think, is fantastic, because it kind of sorts everyone out very quickly. And what they will do is every single week somebody accesses SilverCloud, they have to do 5 PROs. So they have to do a PHQ-9, they have to do a GAD-7, they have to do a work and social adjustment scale, and 2 others. They're asked 49 questions when they log back into SilverCloud before they're actually able to get into the content of it. And when I tell people here, their mind is amazed by this. How is this possible? That's just the rules over there. And that's every single week, so they can measure changes pre-post and even midpoints as well. So you're seeing the more severe based on those indexes.
Interesting. So Yana and Lindsay, why don't you share with us, so what are you seeing in terms of severity of conditions, and are there certain types of conditions that are more prevalent now since the pandemic has occurred?
I mean, definitely depression and anxiety, but we've also seen a huge increase in alcohol use. Yeah, I think that's, the coping skill, a lot of, or the tool, what people went to during the pandemic, just drinking, increased alcohol consumption, and then opioid use disorder. I mean, those are really our top 4 that we've seen with this. So, and I think that's where, to a combination of, I think the hybrid model, like Lindsay was talking about, for a lot of our patients. I mean, with some of the, right. So I think the other thing with telehealth is really, it's looking at your patients, somebody with agoraphobia, right? Not like, telehealth is really great to use and building some skills, and then kind of working with transitioning them back in the community, right? So that's somebody where telehealth is really great to use it with. But then you have some population, maybe some schizophrenia, or some, actively psychotic, where telehealth is not the tool or the modality that you want to use. So it's really looking at, I think that's the other thing with telehealth, it's really looking at your patient and determining sort of which modality works best for them. And for some, it might be just telehealth, for some, it might be in person, but I think for many of them, it's going to be a hybrid model.
Okay, interesting. Lindsay, I don't know if you want to comment.
Yeah, just a quick addition. I think, there's the diagnoses, and that certainly the increase of substance use and the worsening of pre-existing conditions. But I find this fascinating, this phenomenon of those of us who are not unwell but we're not well either. And just sort of the way that the constant kind of decision making or stress or unknown, the weight of 18 months of that on a human brain just kind of dulls it, frankly. You know, it's harder to kind of get through the tasks and day-to-day responsibilities with the same like enthusiasm and energy and motivation and satisfaction than we may have in the past. And you know, I think it's very interesting to think about those of us who are maybe aren't, you know, don't reach criteria for a diagnosis, but just are not at our best. You know, Silver Cloud released a report on employee mental health, and I think it really touched on that. How you know, there's this component of folks who are just this term languishing, which is you know, is refers to, you know, this place between well and unwell, and it does put us at risk for developing you know, diagnosis of depression or anxiety or substance use, et cetera. But also is just it's an uncomfortable place for the average person to be, which then can be kind of distressing in itself. So we do know that certainly exists as well, which is I just think it's an interesting phenomenon that I don't think many people talked about before.
And those folks that are languishing are seeking help through virtual care?
I think some are, and then some maybe some are and some aren't. I think some, you know, are not sure what we can do about that. And, you know, I think that, you know, Silver Cloud's report also made a good point of just, you know, giving people space, whether it's an employee or an employer or, you know, an organization or giving people space to be not okay and to kind of like put words to the experience and have a conversation is important for that type of population.
So interesting. Really interesting, and the term as well, very interesting. One thing I wanted to touch on was the health disparities issue. And we know that virtual care has really extended access just from all kinds of studies over the last year to people that would not normally be able to access it because it's more convenient, you don't need to leave work, etc. Can you talk a little bit about, do you think there's kind of an equitable access now for the underserved, that we have this in place? I'm not sure, Yana, if you want to answer this, or Lindsay, if you want to take a stab at it, but you know, does everybody have access to this virtual behavioral health care?
No, I mean, we have patients that struggle because they don't have internet, they don't have data, they don't have the right technology. We also, about a year ago, brought on a virtual technical specialist. So she will do sort of all sorts of troubleshooting with patients, right? Downloading the app, setting up accounts, audio isn't working, right? So because those are things that the clinicians, right, all that troubleshooting we're doing for a little bit. And that's really, I mean, we want the clinicians to do therapy. So she has been amazing and, you know, really helping patients and outreaching and trying to troubleshoot with them. But some of our patients don't have internet. Some of our patients don't have smart devices or cameras on their computer. So there's some resources, you know, we try to connect patients with those, but some patients just aren't able to connect.
Yeah. I mean, one follow-up question to this, I would say is, and I know that there's a lot of advocacy efforts right now pushing through for audio or just voice calls without the video being provided in behavioral health, and having there be equitable reimbursement, whether it's a phone call or you're seeing the person. Do you guys provide kind of just the voice calls, or is it primarily, you do? Okay.
So we do in person, we do telehealth, and we do phone.
Okay. So that seems like that would be really key and really valuable in terms of equitable access for a lot of these groups.
Absolutely.
Great. Lindsay, did you want to jump in?
Just exactly that. I think that certain groups are doing far more phone sessions than video. You know, if you don't have that access, it's also, I think, a comfort level for some folks. And I mean, frankly, there's pros and cons to all approaches here. And so, you know, I'm an advocate for video because it gives you so much more information and has a connection. But I also know that there's benefit to phone. Like it feels a little bit safer. It's a little less uncomfortable, you know. So so the legislation around, you know, reimbursement for phone only and you know, expanding high-speed internet access, giving hotspots in communities that need it, you know, these are all so important because telehealth helps, but we're nowhere near like getting everybody service that deserves it.
Yeah, and I just want to respond. I know we've got a couple of questions in the chat box about phone only and reimbursement issues, and that is actually right now something we're advocating for with Congress, and a number of organizations, hundreds, are really pushing for this parity because it was allowed momentarily because of the pandemic, but I think we're really trying to make sure that this is clear cut and sticks around. So we'll hopefully everybody keep everybody up on that, and hopefully we will land in the right place on that. Let me go over to Ken if we could. You know, can you talk a little bit more? There are some questions kind of about virtual platforms and how this works exactly. Can you talk a little bit about the cognitive behavioral therapy piece and what does that look like? How do you do that on a platform?
Yeah, certainly. So I'm a layperson. I'm not a clinician. My understanding, how I suppose understood it from being on the other side of it, CBT, cognitive behavioral therapy, is, I suppose, really around the approach of, say, for example, I attempt to cook the dinner, and I burn it. So I burn or ruin the dinner, which happens more often than not. So the cognitive bit of that is, I think I'm worthless, I'm useless, and I'm no good. And the behavioral piece of that is, I will perhaps lash out with my wife or my kids, or be short, or snap. And CBT is about the combining of those together and the understanding of how you can take your thoughts, your feelings, and your behaviors, that TFB cycle, and essentially break it. So break that cycle, or that automatic link that we can that we can often find ourselves slipping into. And, you know, was a mention around alcohol and other types of use, because people are using that to help them as a kind of crutch. But what the purpose and point with SilverCloud, we're delivering via text, audio, infographics, quizzes, etc., is a tool chest, or a method of them being able to learn these different tools, that they can catch that in the executive function part of the brain. They can catch that data that they're taking in, or that input that they're taking in, and it might be what their colleague called them on a call, or said to them, or didn't say to them, and how I'm now going to react to it. That's what you're teaching them. Maybe around catastrophized thinking, or negative thinking styles, or those types of things. Again, a toolkit to help people be able to use and then reapply, be it at social events, be it at normal day-to-day life, whatever it is. That's what we deliver out to people.
Ken, one more question while we've got you. Great question in the chat box here, Q&A box, is there are so many mental health apps out there, and employers, you know, payers don't necessarily know which ones to recommend. So is your tool being specifically prescribed? It sounds like you're in some mechanism to do that by physicians. How does that work, you know, particularly in the US as well?
Yeah, there's been a huge proliferation, a huge, dare I say, overinvestment in this segment and in this industry. And I say overinvestment because I think there's a very large challenge where we are today, that there's more marketing than there is substance, more marketing than there is clinical rigor, evidence base, validity of what organizations are doing. And I think that is not good. It's not good for anyone. It's not good for the industry, but most of all, it's not good for that end user, who maybe this might be their first time they're trying therapy, as was mentioned here. This might be the first time they're using this as a stepping stone to help them with some of the challenges they might have. And the worst thing that we want is them to get turned off from it, or rejected from it, or feel this doesn't mirror me, or whatever it might be. So I've a huge challenge with the industry today in terms of where it sits right now, where most of the companies in the space are marketing companies, more or less, with a little bit of science behind them, or a little bit of clinical behind them. I'm not going to be very popular for saying that, but that's the kind of honest truth in terms of how I feel. And when we talk to organizations, be they systems plans or employers, they're kind of being bamboozled with marketing material that's hitting them, promises of this and promises of that. But then when they deploy, the data dries up very quick, and the live dashboard that we were promised isn't actually accessible, and all these different things happen. Yeah. As I said at the start of the call, digital delivery of mental health is infinitely measurable. It is measurable across the key areas of: was this engaged? Did the user activate? How much content did they ingest? When or how often were they accessing it? What was the pre and post of it? So did it make a clinical change, and was it clinically significant? The lastingness of that change, and the user or patient satisfaction. So we ask a user at the end of each module or each session with us, was it helpful? Was it relevant? Was it interesting? Was it supportive towards your goals? 4 questions. Every single person gets asked that. And they would say, strongly agree, disagree, or strongly agree against each one of those, so on a Likert scale. And we've over 94% user satisfaction rating today. And that's all the way back over 12 plus years of our lives. And it's not an advertisement for us. It's just more, I'm kind of calling on the industry to sort of say, we need to kind of clean up our act in terms of the clarity of the data, what we're doing, where we fit in within the care continuum. And I suppose from a Silver Cloud perspective, we power the health systems, the health plans, for them to deliver out care, and we're trusted by them. And I think that's probably the best place you can start. If those organizations are using us for their patients and indeed their own employees, I think that's kind of a good sign in terms of having a real partner.
Yeah. So let me ask Jana here. So Jana is someone, a health system that shops for these tools to provide, do you guys have some, are you looking for a certain good housekeeping seal of approval? Is it kind of each clinician on their own in terms of what they recommend? Do you have any suggestions on that end?
As far as what they recommend, the course of treatment?
No, a digital tool.
Digital tool. So as far as digital tools that we recommend for our clinicians, so we're not linked with any big ones. We're looking to expand.
But nothing yet.
Yeah.
Okay, let me get to another great question here, asked in a couple of different ways about, and I love John Miller who asked this about virtual care not requiring the same amount of real estate as in-person care, so staffing. Let me ask this to Lindsay and Jana. So we know there's a staffing issue right now. So can you talk, first of all, let people know what that issue is, and how you guys are dealing with it. Lindsay, do you want to jump on that?
Sure. So I think I was also reading that question. I think if I can, the theme is, does the reimbursement for services delivered via telehealth need to be as high because the cost may be lower? And I mean, my opinion is that is a misunderstanding, that there is a lot of background support that goes into running a smooth, safe, effective, and high quality telehealth kind of delivery of care. So, I'm a psychologist, I'm not a finance person, so I won't go as far as to say that in some ways it's even more, but that is a falsehood that I think it costs or needs any less support. And in my opinion, I think this is one of the big problems is that we need to make sure that we are valuing mental health care and reimbursing it in a way that encourages people to pursue master's and doctoral and licensure and delay work and delay income and incur more debt to do this type of work. And it's true for physicians and other healthcare providers as well. We've got to make sure that we are taking care of our providers, and in my opinion, any thoughts around decreasing reimbursement is the exact wrong, sort of a step to take. Or I think that we have to do something around And I know it's not an accusation. I know that this is just a topic that comes up, and as you can tell, I'm passionate about it. It's like this, it's hard to deliver high quality care with measurement and outcomes, and these things cost money, and we need to encourage folks to, want to do this work.
Well, let's piggyback on that for a second, Yana. So, I mean, you're out there actually training folks who are using this. What do you find are some of the biggest challenges to their adoption or barriers to them adopting virtual care?
I think now, Lindsay spoke to this earlier, we're so used to being in the virtual world, right? I think initially, right, it's just something new. It's something different. I see my face on the screen. That's uncomfortable, right? So like those things are just initial when we talk about training and bringing new staff in, looking at the camera instead of looking at somebody's eyeballs on the screen, right? Those are all just new things we have to learn and we didn't think about prior to that. But I mean, our clinicians are all using it. There isn't a single, so like on any given day, we have about 200, like I said earlier, 200 different practitioners on the platform. So all of our clinical staff is using it. I think initially we were doing a lot more phone visits, right? Mm-hmm. Because that was part of telehealth, included the audio only. But then sort of really as we've transitioned and people are getting more comfortable now, everybody that's coming in, I mean, we're doing a majority telehealth and really a lot less phone. So I think now staff is really just comfortable, but I think that was one of our biggest barriers, just getting everybody comfortable. I did practice sessions with everybody, right? Where I just said, hey, why don't you schedule it and we'll have a session. I'll show you where the, on off button is, how to kind of have the session. So that was initially, but I think we're at a really good place for our organization with telehealth.
Yep. Well, it's actually, I'm just looking at the clock. It's actually 2:00. So somehow this went much faster than I thought it would, and we didn't get through quite all of the questions. But I do want to I think this has been such an interesting conversation today and really helpful and meaningful. And it's great that all of you agreed to share your experiences and your learnings with us. So I do appreciate that. So I want to thank Ken and Lindsay and Yana today. I want to thank Amwell. And thank all of you for joining us. There will be not live, but a recording of this conversation available online later this afternoon, and we will send out the link of that to all of you and any other resources that any of our 3 prestigious speakers would like to send. So thank you for joining us. Hope everybody has a wonderful afternoon and stay healthy.